everyone. Welcome to the ATI seminar today. I am Janet Elliott, a member of ATI and a professor in chemical materials engineering and also lab medicine and pathology. I'll start today with a land acknowledgement. We acknowledge that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. I'd also like to thank Estellas for their support of the ATI seminar series. And then I have an announcement that the 2026 ATI Research Day will be held on March 25th. And we're pleased to have Dr. Karan Kush from Stanford University as the keynote speaker. Please register and submit your abstract and encourage your trainees to present their research. And I just want to let you know also that the deadline to submit your abstract was going to be today, but we're extending the deadline for another week until January 21st at 12 noon. So now I have the great pleasure of introducing today's speaker. Ivan Ma is currently a PhD student in the Department of Surgery under the supervision of Doctors Andrew Pepper and Greg Corbett. Ivan received the Jamie Fleming Undergraduate Studentship Award in 2023. And the research work that is going to be presented today is from the research that Ivan started during his undergraduate studies, and the research is supervised by Doctors Jayan Nagendran and Jason Acker. And his title is Whole Organ Cryopreservation of Rodent Lungs and Liver. And I'll let Ivan go ahead.
Well, thank you for the wonderful introduction. And yeah, just adding on to that, this was previous work that I conducted in a previous lab, and my current PhD work is separate from this. And so starting off, I have no conflicts of interest to declare. And we'll start off with talking about, again, the learning objectives for this talk today. Firstly, starting off with highlighting the potential of cryopreservation as a pathway forward towards scalable organ banking. Secondly, to present evidence supporting the safety and efficacy of novel ice recrystallization inhibitors, or IRIs, in achieving successful permeation of whole rodent lungs and liver. And thirdly, to report first-in-field experience using ex situ organ perfusion, or ESOP, to deliver non-toxic ice recrystallization inhibitors and to demonstrate their capacity to suppress ice recrystallization. So I'll start off with a little bit of background. We know that with really all organ types, the number of transplants that are being conducted yearly has only been ever increasing. And so with this figure in the US, the number of transplants for the lung, you can see that 2024, the number of transplants done is higher than all previous years, and as is the case with the liver. Now, this may be a good thing. You could say that we're able to conduct more and more transplants every year. But on the other hand, there is also the issue that there's ever increasing demand for these surgeries. And so transplantation still remains the primary treatment option for patients living with failing organs. And unfortunately, organ transplantation really only satisfies 10% of those on the waitlist worldwide. You can see this figure here, which is based on Canadian statistics. In the bar in purple for the kidney, you can see this is the number of people who had surgeries performed. But just below it in the dashed bar, you can see this is the number of people still on the waitlist. And so this differs from organ type, but you can generally say that for the people on the waitlist, it's either equal to or even double the number of people who actually received the transplant. And just below that, I want to point out that there are even a number of patients who unfortunately on the waitlist pass away while not having received that organ. And so this is an unfortunate reality that we face with organ transplantation because of such high demand and such a shortage of them. And one of the main contributors to this issue is the fact that we just have such short preservation times. And this often contributes to both a low utilization rate and poor allocation. Now, even with the addition of extended criteria donation to try and improve the number of organs that are usable for transplants, this still risks early graft failure. And these patients are often immunosuppressed, and there's at risk for rejection and infection. And it's reported that around 40% of lung transplant recipients develop chronic lung allograft dysfunction in 5 to 7 years. And what results in these patients having to rejoin that waitlist and get another transplant. So now let's talk about well, what current preservation strategies do we use to preserve these organs for donation? And starting off with the most basic, of course, is cold static preservation or static cold storage. And this has been an acceptable practice for storing organs for many years now, and primarily involves taking the whole organ and storing it in some type of preservation solution. And that oftentimes can differ depending on the specific organ type. And then this is stored on ice, usually at around 4 degrees Celsius. Now, this allows us to preserve the organ for up to a few hours, and sometimes even just under a day, depending again on the organ type. And so you may ask, why cold temperatures in general? And it's well understood that hypothermia is able to slow down cellular metabolism. And as a rule of thumb, organ preservation through hypothermia slows down metabolism by twofold for every 10 degrees decrease in temperature. Now, while this may hinder organ deterioration, the longer ischemia time the organ faces, the higher the risk of organ dysfunction later on during reperfusion in the recipient. Now, this is called ischemia reperfusion injury, also known as IRI. But for the purposes of this talk, anytime I refer to IRI, I'll be referring to ice recrystallization inhibitors. Now, another preservation strategy is, of course, dynamic in situ organ perfusion. And really, this is a platform where we're able to evaluate, assess, and improve the function of these organs in a semi-physiological state prior to transplantation. And what happens is usually these organs are hooked up to both a pump that circulates perfusion solution through the organ, as well as an oxygen membrane to allow gas exchange. And then for the case of the lungs, there's also a ventilator. And this has been shown in literature to be able to improve preservation times for the lungs up to 12 hours. And one group, they were able to extend preservation for up to a week in livers in this active metabolic state, right? These organs are functioning and working. Now, for our experiment, what's really important is this platform also allows us the chance to manipulate these organs to improve transplant outcome. Now, of course, there is also a combination of these two where you may first store these organs in static preservation solution before you move to a perfusion apparatus. And this has also been shown in literature to improve preservation outcomes in porcine lungs up to 72 hours. Now, of course, there is also cryopreservation, which is storing biomatter at sub-zero temperatures for future use. And theoretically, this allows us to store organs for indefinite periods of time, allowing us to make a repository or organ banks of different types of organs. Now, of course, there are still risks, one of them being cryoinjury, which involves two primary mechanisms of intracellular ice nucleation and osmotic stress as a result of the fluctuation of water as ice grows either extracellular or intracellularly, which causes the cells to either shrink or swell beyond tolerable limits. Now, because of this, there is an optimum freeze thaw rate that needs to be achieved in order to have the successful cryopreservation and minimize that ice growth and osmotic stress. Now, what are the current strategies of cryopreservation and what are some of the recent breakthroughs we've seen in the field of cryopreservation? So starting with supercooling, and this is a sub-zero preservation strategy where the organ is cooled just below 0 degrees Celsius, and it's kept in this unfrozen state where we use mild cryoprotectants and we handle it very carefully to prevent any ice from forming. And so in this paper, they were able to take some unutilized human livers and they were able to successfully cryopreserve them at around -5 degrees for just under 24 hours. Next, there is the method of vitrification. And this is now a deep cryogenic preservation strategy where we use very low temperatures such as -150 degrees, and we use very high concentrations of cryoprotectants. We rapidly cool the organ and we turn all of that water in the organ into this amorphous and glassy state. Now, this often requires specialized rapid cooling, rapid heating, and uniform rewarming later when you're trying to recover the organ. And so with these two studies, they were able to show this novel approach to induce uniform warming by loading these organs with these ion particles and then using a magnetic field to induce very uniform heating in these organs. Now, however, these studies are still limited to small animal models and still have to be scaled up to human-sized organs. And the fact that you have to use very high concentrations of cryoprotectants, which have been shown to be toxic to some cell types. And finally, there is also partial freezing. And this is a high sub-zero preservation strategy, usually around the -10 to -15 degrees Celsius range. And this is where we have controlled ice formation, usually limited to the extracellular ice. And this is formed in the presence of cryoprotectants to maintain an unfrozen liquid fraction. And this reduces the metabolism without fully freezing the organ. And so with this study, they were able to successfully partial freeze these rat livers and preserve them for 5 days. Now, this same group, even more recently, has been testing this on human livers, and the preliminary results actually indicate viability after 10 days of storage. Now, there are these many different strategies in which we can induce cryopreservation, but all three of these still have one major issue, is that the major concern of injury of the organ occurs during the rewarming phase of these organs when you're getting them ready to be used. And why is that the case? Well, there's this phenomenon called ice recrystallization. And essentially what happens is that during any freezing or thawing events, existing ice crystals, larger ones, will start to grow and expand, absorbing smaller ice crystals. And this is the source of major damage, cellular damage, and reduces the post-thaw viability of many organs. Now, there are, of course, ice recrystallization inhibitors. These are small carbohydrate ice control agents that mimic naturally occurring antifreeze glycopeptides, which can be found in many freeze-tolerant animals like the wood frog. And this is where partial freezing is inspired by. However, these IRIs are easier to synthetically make in scalable, less toxic, and they permeate faster than some of these glycopeptides. And in literature, IRIs are already used for cryofreezing of red blood cells, hematopoietic stem cells, and endothelial cell lines. And so the goal of our project is really to use this in a large whole organ model. And so starting with our experiment, the liver cryopreservation, here's our experimental protocol. And of course, I have to give credit to both my mentor and friend, Syed Himet, where this work was primarily one of his chapters for his thesis. And unfortunately, he's traveling right now, which is why he isn't able to present some of his work. And I'm here on his behalf. And so just starting from the left side here, we have a schematic of our perfusion apparatus. We had 3 groups of Sprague-Dawley rat livers that were procured and then randomly assigned to either an IRI group or a control group, and then perfused for 4 hours at 32 degrees. And so we used 2 notable commercially available IRIs. One of them is called 2FA and the other is called 4CLA. And we use a concentration of 15 millimolar for the 2FA and 8 millimolar for 4CLA. And these concentrations were based off of previous studies that found that they were successful in cell lines. And so then these IRIs are dissolved and mixed into the perfusion solution. We use Williams E media, and then this is circulated and perfused throughout the organ over the 4 hours. And so over that time, we also monitor physiological parameters. We look at the liver function, as well as also taking blood gas samples to look at oxygen uptake. And we also collected bile secretion. And after the perfusion, we also weighed the liver to look at edema formation. And then we took a core biopsy, which we then cryofroze and subjected to a freeze substitution protocol, which allows us to then visualize the ice grains. And then here you can see in panel D, we have selected 3 random portal veins in the tissue, and we've highlighted in the colors the ice grains that are identified around them. So I'll start off with showing the physiological data that we have. Starting from the very left, we have the portal vein flow. In the middle, we have the portal vein pressure. And then at the very right, we have vascular resistance. And so with these livers, we perfused them through the portal vein, and we initially targeted a flow rate of around 1.5 to 1.8 milliliters per minute per gram of liver tissue. And then portal vein pressure was monitored every 15 minutes, and then vascular resistance was calculated from those 2 metrics throughout the perfusion. And so because we wanted to maintain physiological portal vein pressures below 10 centimeter water, This corresponds clinically to a range of 5 to 10 millimeter mercury. We had to adjust the flow rate as needed. And so as you can see, in some cases, this required us to reduce the flow to prevent any type of excessive vascular pressure. And this is why you see that difference in a control group compared to the 2FA and 4CLA. And this isn't totally unexpected. With the addition of these IRIs into the perfusion solution, these are carbohydrate-based molecules, which are expected to increase the viscosity of the solution, which would increase the pressure. And in order to maintain that pressure, we would have to decrease the flow. But more importantly, though, the vascular resistance, which is calculated by the portal vein pressure divided by the flow from these two metrics, remain comparable between the three groups. And that's what's most important. However, we did see that over the course of the perfusion, the vascular resistance did increase from time 0 to T4, which does indicate to us that there is general decline in liver function. Now, building on what we saw with the decline in liver function in the previous slide, we wanted to look at biochemical markers for hepatic injury during the perfusion. And so from those blood gas samples that we collected hourly, we were able to measure the release of lactate and potassium, which are used to reflect metabolic stress and loss of cellular integrity. And so consistent with what we saw previously, there was declining function as indicated by the ever increasing levels of lactate and potassium. But what's the most importantly take away from this is that it's comparable across all groups, which indicates to us that it isn't necessarily a treatment-specific effect from the IRIs. And so now we wanted to look at some of the functional outcomes of these livers. And so starting from the left, we have our wet-dry weight ratio, and this is a measure of tissue edema. In the middle, we have our oxygen uptake rate, and then on the very right, we have our bile secretion. And so there was no significant difference in edema across all three groups, which was good. And additionally, we didn't see any significant differences in the overall oxygen uptake rate. However, we did see in our 4CLA perfused livers, they failed to secrete any amount of bile, which may indicate some type of impairment in biliary function. Next, we also wanted to look at the liver enzymes as well as the ATP levels. And so starting with ALT and AST, you can see that over the course of the perfusion, or from T0 to T4, the ALT and AST liver enzymes drastically increased, which are markers indicating to us that there was hepatic cellular injury. Now, what's important again is that this is consistent across all three groups. So again, reinforcing that this is a global hepatocellular injury rather than treatment specific. Now, it's also important to note that although we saw this type of injury, the ATP levels were comparable across groups, reflecting that there may be at least some active metabolic function. Next, we also wanted to look at structural injury. So from those histological sections that we took, we sent them and blinded them to a pathologist for independent scoring using a standardized injury criteria. And so what you can see here is that injury score out of 12. It's very comparable across all groups, and the type of injury that they noticed was specifically vascularization and necrosis. So now moving to the second half of the experiment, where we're now really looking at ice formation. So briefly, with the freeze substitution technique, this was an established protocol that was optimized and adapted from Jason Acker's group. And so we follow this. This allows us to fix these ice grains and preserve their structure so that we can then visualize them in histology. And as you can see here, these white spots are the ice grains. And so now looking at our ice grain number and size as a function of the distance from the portal vein, we wanted the spatial analysis approach to really focus around the portal vein, as this is where, of course, the entry point for the perfusion of the liver. And so what we did was we had these 0.8 millimeter regions surrounding 3 randomly selected portal venules in each slice. And then that region was further subdivided into 100 micrometer intervals. So this allows us to assess how far each permeating ice control agent penetrates into the tissue. And so on the very left here, we are looking at the number of ice grains as a function of distance from the portal venule. So as you can see here in the 0 to 100 micrometer range, you can see that 2FA was actually significantly less ice grains than the control group. But then in the 200, 300, and then subsequently 400 ranges, it was all comparable across all groups. More interestingly, though, in terms of the ice grain area, we can see that 2FA was actually able to control the ice grain size up to 200 micrometers away from the portal vein, while the 4CLA was actually able to control ice grain area up to 400 micrometers away. Now, this indicates to us that 4CLA may be able to permeate faster or more rapidly than 2FA, and that allows it to reach more distal regions in the tissue. And so this leads us to our overall conclusions for the study, where that firstly, the higher molar concentrations of 2FA were non-toxic to rat livers. Again, this was actually the maximum solubility that we could use for 2FA based on previous studies. And of course, it was shown to be non-toxic. And then also that 2FA, again, was able to control ice grain size up to 200 micrometers away from the portal vein, while the 4CLA was able to reduce ice grain size up to 400 micrometers away. Although 4CLA permeated faster than 2FA, the 4CL livers didn't produce any bile and showed macropathological features of bile stasis. And so next, we move to the lung cryopreservation. And so this was the project that I undertook. I was really fortunate to be supported by the ATI through a summer studentship to pursue this project. And it's actually very similar to our project in the liver, where you can see here the perfusion apparatus is almost identical, except now we also have the addition of a ventilator. So similarly, we had Sprague-Dawley rat lungs that were procured and then randomly assigned to only two groups this time. We only tested 2FA and the control group. We perfused them for 4 hours under normothermic conditions. And then during that perfusion, we again monitored physiological parameters. We took blood gas samples. And then after perfusion, we weighed them to assess edema formation, as well as taking core biopsies. And so these core biopsies were taken from the same lung and then divided into 3 conditions. We have a non-frozen control group, so no freezing at all. We then have a frozen control group where we snap freeze these cores in liquid nitrogen. And then we have a transient warming group, so TW. And in this transient warming group, we do the same thing in the frozen. We snap freeze them in liquid nitrogen. However, after that, we expose them to a brief rewarming period up to minus 20 degrees Celsius. And then following, all these cores are then subjected to that freeze substitution technique to visualize the ice grains. And so with the transient warming event that we introduced, the goal here is that we're really trying to simulate a thawing event that induces ice recrystallization. And this allows us to really properly test the ice recrystallization inhibition properties of these IRIs. Now, we attempted a similar protocol with the liver experiment, but at the time it was still being optimized and was ultimately unsuccessful. So the ice grains that you see from that experiment were just from frozen slices. So here's a video that is a combination of both the liver perfusion as well as the lung perfusion a little bit later. So here you can see that it's cannulated through the portal vein, and then we have another one collecting bile. Here's the lung. You may wonder why the lung is so white and pearly. Well, prior to procurement, we actually flush the lungs and remove all any blood. Okay, and then next, moving to our physiological parameters. So starting with edema, we saw that it was very comparable between the two groups. And for oxygenation, that was the same story. It was very comparable, no differences. Now, when you look at compliance, you may see that comparing between groups, so controlled 2FA, it's very comparable, but you do see that there's a significant difference from T0 to T4. And really the reason for this is that compliance is a measure of elasticity of the lungs. And so as you perfuse, this actually recruits the lungs and improves function. And as they open up, that compliance also increases. So really this shows that functionally the lungs are improving over the course of time. And that's the case for both the control and 2FA. Now, for the pulmonary artery pressure, you do see here that in the 2FA group, there is a significant difference from T0 and T4. And again, this isn't too surprising because similar to the liver, with the addition of the 2FA being a carbohydrate-based molecule, this increases viscosity, and so we may see an increase in artery pressure. What's more important, though, is that the vascular resistance was not significantly different between the two groups. And with the lung injury score, we did the same thing. We sent this off to a pathologist. And as you can see, there's also no significant differences. Now, looking at some of our histology imaging, so we have non-frozen, frozen, and transient warming at the top here, and then control, and then 2FA. And of course, you can see that in the frozen, I'd like to draw your attention to the blue arrows. This is where we identified ice growth around these lung parenchyma. And then with the red arrows, and this is really one of the limitations of the study and really this lung model, is that this is indicating alveolar spaces. So we weren't able to visualize the ice in these air spaces, and that's something we're currently actively working on to address. Nonetheless, though, we were still able to quantify the ice grain area around those perivascular and peribronchial regions. And so starting here, you can see with just the control group, and really the purpose of this for frozen and transient warming is to again show that the transient warming protocol is capable of inducing ice recrystallization. And as you can see here, it was in fact successful, as the ice grain area for the transiently warmed group was significantly larger than the frozen slices. And so now let's look at this in the 2FA treated lungs. And what you can see here now is the ice grain area for the transiently warmed slices is now very comparable and not significantly different from the frozen group. And this really indicates to us that the 2FA was successful in inhibiting that ice recrystallization during that simulated thawing event. And so again, reiterate some of our conclusions. The 2FA was non-toxic to the rat lungs over the 4-hour perfusion and showed ice recrystallization inhibition benefits during that brief freeze-thaw event. So now, what's next? Well, what I present today showed that ice recrystallization inhibitors, IRIs, are non-toxic in both the lung and liver tissue and can effectively inhibit ice recrystallization. So far, this work has been limited to just the tissue slices, and whole organ cryopreservation has not yet been performed. And so the impact of these IRIs on post-thaw liver and lung function at the whole organ level still remains unknown. And so that's one of the future directions that we're looking toward, is to combine these IRIs with permeating cryoprotectants in combination with one of those previous strategies, such as partial freezing of the whole organ. As really the whole goal of IRIs isn't necessarily to say this strategy is better than those other ones. Really, it's a supplement that we're going to add to improve any one of those strategies so that we can really mitigate some of the injury that occurs during the rewarming of those organs. And so really this will help us determine the protective effects from tissue slices and carry that over to intact organs. And when we combine that with the partial freezing protocol, we can then assess those organs through recovery, either through further perfusion or then performing a transplant. And overall, that's it. I'd like to thank, of course, my supervisors for this project, Dr. Jason Acker and Dr. John Nagendran, all of our lab members, as well as Panthera for donating the RIs, and of course, the Alberta Transplant Institute. Thank you for listening. If you guys have any questions, I'd be more than happy to take them.
Okay, well, I'll just ask one question then. What's next for this research, Ivan?
So I think, I'm not sure who, because both Syed, he's graduated, and I think he's looking for a postdoc position somewhere else. And then I'm currently in transplantation research, but focused on type 1 diabetes, more so in islet transplant. So I'm not sure who necessarily has taken up this project, but I think maybe Nishaka and Dr. Acker's lab is working on it, maybe some more. But really, I think somewhere that they can go further is really this area of ice growth in these alveolar spaces. This was something that we attempted to look into right at the end of my project to try and figure out if we can quantify that, as this is quite a big limitation because we don't really know what's going on in these air spaces, right?